I'm Rachel Hassani, and I'm the Director of Education and Engagement for the Missouri Rural Health Association. And today we are thrilled to welcome and partner with Teleneph. We're going to have an in-depth discussion today about options for telemedicine nephrology services for rural hospitals. If you have any questions throughout the webinar, please feel free to just drop those in the chat, or you can reach out to me directly with anything else. My email address is there in the chat as well. So today we will be recording this webinar and then posting it afterwards to MRHA Connect. You can join us there to share the presentation with your colleagues or post any follow-up questions. We'll also have an asynchronous chat after this in a discussion thread where you can post any follow-up questions or continue this conversation right there. I'll post the link to that in the chat as we move along towards the end. We'd also like to invite you to our next webinar, which will be July 8th at 12 o'clock. And that is with our partners at Show Me Echo, the extension for community health outcomes. You're welcome to join us for any of our upcoming webinars, but we definitely hope to see a good group there for our next one on July 8th. With that, I'm going to pass the mic right on over to Ron Kubitz and Rhonda Mason with Teleneph. Ron and Rhonda, the floor is yours.
Well, Rachel, thank you very much. And thank you for this opportunity to speak with your wonderful audience. And first of all, I'd want to wish everybody a wonderful first day of summer out there. I don't know about you, but I think summer's been here for a couple of weeks already. But, it's the first day, so let's enjoy the moment there. We're excited to actually speak with you. Teleneph focuses on nephrology services to the rural community only. We're only serving rural hospitals, critical access hospitals. What we're focused on is, letting the rural hospitals actually take care of patients that live in their community. And we started this program over about 5 years ago in Globe, Arizona, which is about 90 miles outside of Phoenix, Arizona, up in the mountains where it's a little bit cooler, only about 10 degrees cooler. So if it's 120 in Phoenix, it's only 110 in Globe. But joining me is Rhonda Mason. And Rhonda was the CNO at this hospital where we actually started our first program. And it's a critical access hospital. Her and her team had no prior dialysis experience. And based upon everything that happened in that, her team brought up this program. In the first year, they actually saw 126 patients. Let me introduce you to now our COO, but the former CNO of Kobe Valley Regional Medical Center, Rhonda Mason.
Thank you, Ron. It is super nice to be here with all of you. As Ron mentioned, and I often say, I am a recovering CNO of critical access hospitals, several of them in my career. I've been a nurse forever, it seems, a long time. And my passion is really rural health. And so probably 25 years ago, when I started working in the rural environment, and absolutely fell in love with what we could do for folks who choose to live in, outside of the city, outside of urban. I've been with Teleneph about a year, and I have the great honor of working with our partners on implementing this project, starting dialysis and nephrology services all over the country. Really, we've been able to help a lot of communities bring this up. So glad to be here.
Thanks, Rhonda. And what we're here to, if I can, there we go. Our story today is about rural hospitals actually keeping their mission, right? Keeping care local for your community, especially with your end-stage renal disease and your chronic kidney disease. We're going to go over, I went and researched all the counties in Missouri. I don't know if you folks know, you have over 100 counties within your state. You have the 5th most counties in the United States. So you have a lot of counties. And the reason why we're focused, and we actually started this in rural America, is because of the cost of transportation. For these patients alone, the cost of transporting a group of patients less than 1 million is $3 billion annually. And we're going to discuss today how rural hospitals are stopping the transfers. Now, a lot of the rural hospitals will go in and they'll take a look at their, number of transfers and things like that and say, okay, we've only transferred this many out. But the real issue is these patients are already told by their existing nephrologist and their dialysis centers where to go in case of emergency. So the patients that are actually you're transferring out are the patients who are not actually listening. Imagine that. Stopping the drive. So when you actually do transfer these patients out, and this is what we've been hearing from CEOs and things like that, is that the loved ones, family and friends go out, they go to the urban market to take care of that individual that has been transferred out because the hospital can't provide inpatient dialysis or have a nephrologist. So what happens? Then they're getting healthcare services outside of your community. This way, our first hospital where Rhonda is from, what they saw was then an increase of their service lines, and they actually started offering new healthcare services to their community. So it's been a win-win for everybody. And at the end of the day, neighbors now are taking care of neighbors, and we're keeping care local, which is the mission of all rural hospitals. So a lot of people want to know, well, how big is chronic kidney disease? Well, 11% of the US population has CKD. So that's over 37 million. 2% of the CKD patients have end-stage renal disease, patients that are going on dialysis. A question asked a lot about it, when we actually go into the program. Well, from a payment standpoint, well, 50% of these patients are 65 and older, so they're on Medicare. And the majority of the people that have started dialysis within 3 months, they are on Medicare. Now, the average patient goes to the hospital twice a year. I know, Rhonda, you always say that that number seemed pretty low. You see these patients because they're high utilizers of healthcare. They come into the hospital often, right?
There are those that, yes, that do utilize the hospital a little bit more than that.
Right. And here, they're transport dependent, right? So they're utilizing a friend, a family member to take them to the hospital when they do have an emergency. And we've already talked about the cost of transportation already. So if here's all, and I'm going to go through all the counties and your county seats and the population as of 2023. 11%, if we multiply that by the population, will give you the number of CKD patients. And then 2% of that are the patients that are on dialysis or they're end stage renal disease patients. If you can take a look at, and I'll go by each county, and Rachel will actually be putting this presentation on site as well, so you can go back and take a look. I think the golden rule of thumb here is that if your community is over 14,000, you probably have the population to actually support this type of program. Carroll, Carter, as you can see in those numbers, not so much. Cedar is right there at 32. But if you go to, down below, they're at 16, probably doesn't hit. The other thing that you need to take a look at as well is what other communities do you serve? This is the only community, but if you're actually getting other members, then you need to do the analysis of the other counties as well. So as you can see, you have a lot of counties there. So as you can tell right there, Davies, DeKalb, less than the 10, 14,000 that we talked, the numbers are lower. But at the other ones, they're high. So I'm going to go just so that you can see it. And if you see your counties, I put this in hopefully alphabetical order. There's Mercer, Miller. Mercer's on the low end, as you can see. And then, of course, the area of St. Louis and the city. I guess you have counties, and St. Louis actually left the county and created their own little environment there as well. But as you can see, there's a number of patients. And here's the other thing that you'll be able to do is the patients that are on CKD, and our whole focus is providing these communities with a nephrologist, and we only provide nephrologists to a hospital because it is about, creating relationships, people feeling comfortable, and people knowing your community. right? The last thing you want is 31 flavors. I might like that for ice cream, but I don't want that in physicians, right? Um, so worth, no, you don't really have the population, but if you take a look at right, they definitely have the population for ESRD patients. So here's the reason why, what we talked about earlier before, that the average patient, dialysis patients are high utilizers of healthcare. And here's the top 10 reasons why they're coming to the hospital. As you can see, it's not dialysis. It's congestive heart failure, pneumonia, respiratory failure, and things like this. These are the things that you could provide service. Now, if you have swing beds, we have a number of people that have, in the rural community that are providing swing beds. Now you can take those patients and actually fill your swing beds with people that are on dialysis. Okay, so that's a win. It's a win-win for everybody because no one wants to drive back and forth. So, why haven't people done this before? And the real reason is these big machines, very expensive, not very portable or anything else like that. Learning curve, and usually you got to have a dialysis nurse. Well, lo and behold, things have changed. Now you have machines that patients are utilizing at home. And our thesis when we go out and meet with the hospitals in rural America is that if a patient can do it at home, a nurse can do it at a hospital setting. And if there's anything I've learned from Rhonda, the nurses in rural America, they're the MacGyvers of healthcare. And we'll talk about that later as well. But as you can see, it's very simple. It's color coded. They provide great 24/7 support. And it's very simple. So if a patient can do it at home, a nurse can do it within a hospital setting. There's two manufacturers that provide these machines. Next Stage is one, and the other one is Tableau. Both excellent machines for you to utilize within your hospital setting. They provide outstanding 24/7 support. And I want to ask Rhonda here about the question when she first did this, right? I know everybody's apprehensive when they bring in a new service line and things like that. Rhonda, you want to talk about the first time you actually did the program and how supportive the manufacturers were?
Sure, and that's definitely so key, especially in rural hospitals where, you know, uh, we are very familiar with how limited resources can be. And so I think one of the big selling points really for both of these vendors is the work that they have done with their support. And I've worked with a lot of vendors who say they have support, and you call the 1-800 number and you wait and wait and wait and wait. And, you get somebody, non-clinical on the phone when you have a question. Not the case at all with both of these folks, Tableau and Next Stage. They have clinical people who answer the phone in moments, anytime the staff call. And as Ron mentioned, the first hospital we brought up where I was the CNO, we had no experience, no dialysis experience. I didn't have anyone on my staff. I am not a dialysis nurse. A little bit of exposure in my career, but not enough to brag about. And we had the vendor actually on the phone when we were stringing the machine for that first patient, when we were hooking up that first patient, and it really helped us to have a very successful start. Because I think also we all know that, nurses remember everything, and we remember when something didn't go maybe as well as planned the first time. And that's the memory we bring along with us. And so making sure that they are there for the nursing staff and supporting them is really um, the mission of these two facility or these two these two vendors. And they really are true to their word. They make it very easy to get this service started.
Thanks, Ron. So when you're taking a look at this, it's what I call the telenephrology process. So the first thing you need to do is analyze the market, right? So as I showed you already, I've somewhat done that for you already. I have a database if you want to ever reach out. send me your zip code, and I have the ESRD numbers by zip code, so I can work with you on that. The other is the financial analysis capability. Everything we do, and Rhonda didn't tell you about me, but I am
Mhm.
bipolar. I have, even though my title is the CEO of the company, I have an accounting degree and computer science degree. I used to work for Ernst & Young, the accounting firm. So I actually provide you with a financial model, making sure from a return on investment that it's a win-win for you as well. The other thing is you need to get consensus. We just got back. We were in Texas working with their med staff, making sure everybody's on board. And then based upon the quick analysis of that, you go in and you determine if it's time to proceed or not to proceed. What I recommend, a lot of people go, which equipment do we recommend? At the end of the day, it's about your clinical team. Which machine, which relationship do they feel comfortable with, right? And what Rhonda brings with her program and her nurse team as well is an implementation program. Because what Rhonda realized was, I wish I had this. I wish I had this. Well, now
Mhm.
she actually gets to help rural hospitals with the program. Rhonda, you want to talk about your implementation plan in that?
Sure, sure. We have a really good opportunity to bring services back to rural hospitals, and I think this is such a unique population. Dialysis patients. There aren't very many uh, diagnosis that you have people that are going to a center, sitting for 3 days a week for hours on end, having dialysis. And then when they need acute care, a lot of rural hospitals don't provide that, don't provide those dialysis services, and don't have nephrology. Nephrologists are incredibly difficult to find. And so Teleneph is able to come in, provide that nephrology service, as well as um, my nursing team here. We really do work with the clinical and the financial team on an implementation plan, uh, staffing models and competency tools and policies and procedures. As Ron said, all of those things that I wish I would have had when I brought up the program. We have a really great toolkit of support. We are keenly aware that every rural hospital is different and the resources are different. And so I think one of the fun and exciting things is to go in and learn about the different organizations in the different states, and learn what your strengths are. It's amazing what rural health is doing and what resources they have, and then also identifying those things that are barriers, and so we can work through those as we get this program up and going.
Thanks, Rhonda. And what I've learned from Rhonda, she told me, if you've seen one rural hospital, you've seen one rural hospital because
Mhm.
everybody's unique. Um, the other part that we focus on is collaboration, right? What we're really focused on is total care of that patient when they come into your hospital. Some people are worried that, their existing nephrologist will be upset or the dialysis center is going to be upset. Actually, the dialysis center is going to be very happy because they're staying in the community and their chairs will be filled. The nephrologists are extremely busy. We actually reach out, talk to them. When your patient is admitted into your hospital, we reach out to that nephrologist and talk to them to learn any nuances about that patient. So it's really about collaboration. Um, we get your coding team involved and everything else. The one thing think is really unique in our market here and how we provide the services, there's 2 dedicated nephrologists to a hospital. As I said, the last thing you want is 31 flavors of nephrology. You want the 2 that know your community and you're getting to know everybody on a first name basis because this is the first time you're doing the program and you want to build that relationship, that trust, and that competency going forward. As Rhonda was talking about, the dialysis equipment vendor support, it's amazing. You get 24/7 support. Also, Rhonda's team of nurses are available for you 24/7 as well. What we're trying to do is help you keep these patients within your community. The other thing we always recommend is, and as our chief medical officer thinks, he always states, think of us as a nephrologist on site 24/7, except we're virtual. So we're talking about inpatient dialysis right now, but if you had a question on CKD or AKI that came in, our nephrologists are available 24/7 to answer any of those questions. The other thing is that we're not charging you for questions. We only charge from a standpoint when you admit a patient. So what we're trying to do is build that relationship of trust and that knowledge of nephrology within your clinical team. The other thing we provide is CME education every 6 months to your team as well. Um, let me go. So, and this is how we work. And what I love, Rhonda and I have been out a number of these locations, is that we tell them and everybody knows there's always that, person in the room that's, you know, as our doctor says, the chicken little. They're afraid that the sky is going to fall down, right? And we're not taking the hard patients in the very beginning. Our approach is crawl, walk, run. Let's build the competency. Let's take the easy patients first. Let's get everybody excited. They feel comfortable about doing these programs. Rhonda, I mean, this is your approach when we first started the program, correct?
It really was, and I think that often in rural hospitals too, we uh, aren't sure, what our capabilities are, or growth and additional, adding acuity to the organization. And so being able to um, really triage patients coming in the door and deciding, okay, is this a patient that we can successfully treat? Really get our nurses comfortable and excited, like Ron said, about the program. And we've seen this over and over again. Yeah, you triage, you bring these patients in that typically you would admit. So they have a little bit of pneumonia, or they have a cellulitis, or something, or a diagnosis that you would most often admit to your facility. Um, but they're a dialysis patient. And so that's always the but. They're a dialysis patient. And so then the transfer process starts. And when you're able to provide that dialysis to them, they're able to stay in your community. And it it has been incredibly successful. The hospital where I was CNO, that's now been doing this for about 5 years, their acuity in their hospital has significantly increased intentionally. They're able to keep sicker patients. They're able to keep their nurses, because their nurses want to learn new skills and want to maintain their knowledge, and life learners. And so it really has added a lot of energy to the clinical staff, as well as expanded other services. So, orthopedic surgeons are thrilled that they can keep a patient in the hospital there, without having to transfer them away. They can do the procedure knowing that the hospital can provide the dialysis that the patient will need, the next day. Cardiac services. Some of our critical access hospitals and rural hospitals have cardiac surgery, our services, and it's been able to expand that. So it really is a phenomenal program at bringing a lot of other services to the community, and growth.
Thanks, Rhonda.
Mhm.
And as we've talked about, it's as Dr. Sahani, who's my chief medical officer, says, think of us as a nephrologist. Ask any questions you like, 24/7. Um, Dr. Sahani, Ron always calls him the Doctor Whisper. He's responsible for making sure the right nephrologists are associated with the right hospital, and building that relationship. We talked about already, we are aligned how you're reimbursed. We only invoice when you admit a patient. We provide CME education, and it's not CAN training. It's training that's aligned to what you need at that given moment of time. The one thing Dr. Sahani's team of nephrologists makes sure, and he believes this is how you build trust, they respond to any call or text within 10 minutes. That is their goal. That is their focus. They are there for you. We already talked about the collaboration aspect of reaching out to their dialysis center nephrologist, because that's one thing that's going to be making your program successful, is that the dialysis center and the nephrologist know that you now have the ability to take these patients. So when they say in case of emergency, they can say, go to your hospital. And that's going to be a win-win. Our account people they all work for Rhonda, and they're all rural nurses. Um, Teleneph works, her team will work on the education, processes and procedures, competencies, et cetera, that we talked about as well. And we work with your team. And from a data standpoint, our nephrologists need 3 feeds. They need an ADT feed, labs, and vitals. So very simple from that perspective. Rhonda, this is where you used to work until you came over to the dark side and joined us. But it's not the dark side now that you're with us. It's very bright now. So we're so happy to have you. You want to talk about your location now?
Sure, sure. And this is welcome to Globe, Arizona. We're 90 miles out of Phoenix. As Ron said, it's about 10 degrees cooler here than it is, which doesn't make it very cool today, I'll just tell you. But very small community, and as you can see, a significant number of ESRD patients. It's critical access, runs a fairly high census of about 22, 23. And they looked at this program for a long time, and it's been so enjoyable to talk with rural hospitals that are really looking at growing services and keeping patients local, and and um, and they're talking about strategies and what would work for their community. And this conversation had gone on long before I got there. And the first year that we did dialysis there, they admitted over 100 additional patients to the hospital, which is obviously significant financially for the organization. This is just a snapshot of the finances because, though I'm a clinical person and it's all about the patient, um, as far as at heart. I have also learned that there has to be some revenue producing for every new program. And so as you can see, I'm not going to go into a lot of detail, but this particular hospital saw a really significant net revenue from this service line, as well as, it really didn't affect length of stay a lot. And that's something that I know we keep our eyes on. And again, the acuity of these patients, starting out with those lower acuity folks to help your staff, get more comfortable, uh, keeping them local and being able to provide this service. So it just gives you a little snapshot. 225 treatments were done that first year. And this particular hospital, it just continues to grow. They're actually transferring patients in from other small rural hospitals in the area because they need dialysis and need other services, which is very unique to rural health. Usually, we're the ones transferring everybody out. So it's really nice to see. People who live in rural America do not want to go down to the big urban hospitals to get care if they can at all avoid it. So it has been great for not only this community, but the surrounding.
Thanks, Rhonda. Yeah, and you've
Mhm.
received patients all the way from New Mexico as well. I know you're getting patients from all over.
Yeah.
And as Rhonda stated, everybody wants to stay in that rural community. They really don't want to go to the urban market. So it's been a win-win for everybody. We're as far north as Fairbanks, Alaska. You think Rhonda talked about 90 miles. Well, in Fairbanks, when they weren't operating this program, they were transferring patients 400 miles all the way to Anchorage. So you can imagine, usually, you can get your coverage of flight down to Anchorage, but no one's flying you back. And loved ones need to go if they want to come and visit you 400 miles away. You're talking about hotel, you're talking about food and everything else like that. Let's keep the patients local, right? So here's a hospital of a rural hospital, a non-critical access hospital. I worked with their CFO and we did the analysis of, if you take a look at by quarter, the number of inpatients. The first quarter they had 22, the second was 27, the third was 27, and then in the fourth quarter as it built up, they had over 40 patients. As you can see, in regards from the net revenue, it played a significant impact to this hospital financially. It's almost $500,000 in net revenue profit for this hospital. If you take a look at it from a standpoint of a hospital runs maybe a 2% margin, the CFO stated, Ron, for us to get this type of margin, that's $25 million of top line revenue we would have to generate. This program has made a tremendous impact on this rural community. Rural health profile. Rhonda, you told me how wonderful all the nurses are. And, when we did the program, some of the hospitals were leveraging the Freseniuses, the DaVitas, and the others and that. And they were nervous about doing this. And now that the equipment, you can utilize the equipment, the same equipment that's being utilized at home, now in a hospital setting. Rhonda was telling me all that, and I came up with the term MacGyvers of healthcare. So all the nurses out there, you're the MacGyvers of healthcare. And I'll let Rhonda talk a little bit more about that as well.
And it is so true. I believe this wholeheartedly. But we do get asked the question a lot, especially from those outpatient centers who have a much more complicated system and equipment, and their training process is very different. And really, when you look at nurses who have committed, clinical folks who have committed to working in rural facilities, they really are generalists. You are the IV team, you're the fall team, you're the code team, you're the everything team. And so the diverse skill set, I think, is something that really allows a new program like this to come in really successfully. I was telling my nurses when we were getting this up and started, if you can manage event, if you can do your own phlebotomy at night when there isn't a phlebotomist, you certainly can start a patient on dialysis and manage the equipment. And then, of course, the critical thinking that it takes. When I talk to my friends who work, are nurses in the urban area, I said, I'm not sure you understand that a nurse assignment in a rural hospital can be everything from an OB patient and a peds patient and an orthopedic patient and a pneumonia all in one shift. And really, I'm preaching to the choir here. So, this is how I think we are able to say this is very doable in rural communities, and we've seen it over and over again be incredibly successful.
Thanks, Rhonda. Rachel, I think